Goedemorgen.
Good afternoon, good evening, everyone. I hope that everyone is safe and sound. I am Noura, and I'll be the host of this lecture today. Today, we are pleased to welcome Dr. Hans, a very special guest from Australia. Dr. Hans is a senior lecturer, speech pathologist, and a clinical epidemiologist with the University of Sydney, who is specialized in assessment and treatment of dysphagia. Dr. Hans, hi. Today, he will be sharing with us his expert opinion on the role of rehabilitative exercise in dysphagia therapy, evidence and directions. With that, I ask that you give your full attention to Dr. Hans. Dr. Hans, the mic is all yours.
All right, thank you very much, Nora. I'll start by sharing my screen, and I hope that this is all working. Hello, everybody. Thank you, Nora, and the Saudi Society for Speech Language Pathology for inviting me to have this lecture. Everybody, a warm welcome. I hope everybody is safe in this time of COVID and all your family members are safe. Special welcome to many of my ex-students that I've already seen going online, colleagues from the Netherlands I've seen, Australian colleagues. It's sort of like, it feels like a reunion, and especially a very warm welcome to my 84-year-old mother who joins us as well. And it's the first time that she's using Zoom. So Mom, I hope everything is all right. So thank you very much. In the next hour or so, a little bit more, I'll be talking you through my ideas about rehabilitative exercise and dysphagia therapy, where we might go with our dysphagia swallowing therapy, and what my personal thoughts are. I'd like to share you a bit of my own research and some of my students' research as well, in what direction we are heading and what we are currently facing and where we're focusing on. But first, let me start off. Whoops, let's see whether things are going well. Yep, click over there. Up, up. You can't start an international presentation without boasting and a bit doing some tourist information about Australia. Always start off with a nice picture of the most beautiful, one of the most beautiful countries in the world, I think. You can see here the Sydney Opera House, the Blue Mountains, some of our famous wallabies. My favorite beach in the Royal National Park, and this is definitely not me because I'm not a surf dude. It's a beautiful country, and I'm very fortunate and blessed to be here and happy to present for you guys. Today's objectives. What we're going to discuss is a bit of the difference between motor learning, skills learning, and muscle exercise, and how basically they intertwine a little bit. Talk about treatment intensity, treatment dosage, because we're going to talk about strength training in dysphagia therapy, and also the role of all sorts of novel interventions in rehabilitation. Everywhere there's something new, you can buy products, there are new ideas, new products on the market, and how do they fit in dysphagia therapy, and is there a magic bullet that works for all? That's a bit of what we're going to do today. Everybody is on mute and their video is shut off. shut off at the moment. Noura already did that for you as the host. If you have any questions, I'll be happy to answer questions or discuss things with you at the end of this, hour. Let's take an hour for this. I've got 75 slides, so I need to talk a little bit fast, I think. At the end, via the chat, we can answer questions and discuss all sorts of things. So let's start a little bit about motor learning and exercise-based therapy and how I actually came to my interest in this point. Now, we can't do anything about swallowing if we don't discuss swallow problems in its general. We know that swallowing problems and always consequences, well, we see daily, we see our patients. So we know the sequelae of dysphagia, malnutrition, dehydration, our biggest find, aspiration pneumonia, which means prolonged hospitalization of patients, antibiotics. There's all sorts of other problems, and most important, of course, and I hope you can see my cursor, there is a decrease in quality of life in patients with dysphagia. Everybody knows that eating and drinking is very much fun. If you see and welcome friends, you always ask, one of the first things you ask is, would you like something to eat and drink? And that is, of course, something that dysphagic patients don't have. So decrease in quality of life, eating and drinking is a social event. But if you look ahead of allied health research, and that's this paper from 2010, and there are more papers in that area about the costs involved in dysphagia. Dysphagia is a sort of medical condition. Patients need to have nasogastric feeds, for instance, or special products that all cost society money. So you see now in healthcare, this since basically a decade or something, you see that you also need to be efficient in your treatment and basically show that in your intervention as a speech pathologist, you can save society money, which in dysphagia we can, because people who eat and drink safely don't get pneumonia and don't need nasogastric feedings. Good for quality of life, good for the money as well. So that is the only slide general on dysphagia. If you talk about dysphagia and dysphagia treatment, you always start with Jeri Logemann. Jeri Logemann is the mother of dysphagia treatment. This is her book, The Evaluation and Treatment of Swallowing Disorders, that she published, I think, in 1985 or something, end of the 80s. Unfortunately, Jeri Logemann passed away, I think, 5 or 6 years ago. With her, everything started in speech pathology and doing dysphagia treatment. Interesting enough, if you read her book, what she always said is that there are 3 pillars in dysphagia management: rehab, compensation, and dietary changes. And the most important thing is rehab. And if you can't do rehab, or rehab takes too much time, you might refer to compensation. Things like a chin tuck, or head tilt, or head turn, etc., etc. And your last resort, number 3 pillar, is a dietary change, so thicken fluids. Now, in the last decades, I think things have changed a little bit, because we tend to do things actually the other way around. If you look at our clinical interventions in dysphagia, you see that most of the time we are doing dietary changes, most of the time even thicken fluids only. Then you teach a patient how to do a compensatory strategy, and if time permits, we do rehabilitative exercises. So that's just the other way around. Now, I know that is mainly due to time constraints, because some hospitals don't allow you to do intensive rehab, but it should be like 1, 2, 3, and we're doing actually 3, 2, 1. And that might be not only my opinion, but a couple of years ago, some Irish colleagues, McCurtain and Healy, published this paper in International Journal of Speech Language Pathology. I almost said immediately dysphagia, because I think everything should be published in dysphagia. Anyhow, why do clinicians choose the therapies and techniques they do? So this is mainly focused on Ireland, and Irish speech pathologists who provide dysphagia therapy. So I don't know if you can extrapolate it to the rest of the world, but it gives you an idea how in a Western country, speech pathologists use techniques and interventions in dysphagia therapy. And the conclusion of this article, which is highly recommendable, dysphagia practice appears highly defined, being characterized by group consensus regarding both preferred treatments and the reasoning underpinning treatment selections. And if you look at the treatment selections, respondents were invited to tick boxes or to tell the researchers what type of exercise and what type of interventions they mainly do in dysphagia treatment. And this is a very interesting table, and some of my ex-students will probably recognize some of this stuff. And you see, number one, the thing we do as most in speech pathology is texture modification. Actually, we do that almost in more than 80% of the patients that we see, we do something with texture modification. Is there something wrong with that? No, I'm not saying that that is something wrong. This is just showing how much texture modification we do. Thickening liquids, position changing, double swallow. Well, if you look down, you see that actually, when it comes to doing real exercises, we start somewhere here with a Moscow maneuver. That's probably the first exercise that we see. Tongue range of motion exercises we'll come to later, because in many instances that probably won't work. But anyhow, looking at exercises, you see that the amount of patients where we do active exercise is very, very low. Shakir exercise in 10% of the patients, and actually going down to my beloved EMG biofeedback, 0.0%. Ooh, still got lots of things to do. But even E-stim and stuff like that, and Mendelssohn maneuvers is less than 10%. So actually this shows you that we are doing the other way around. We do a lot of food interventions, dietary interventions, some compensation, and if there's time left, we do some exercises. And that might be not the most efficient way to treat. Now, when I came to Sydney Uni in 2013, I actually migrated 7 years ago to Australia, and this is our main campus building. Our faculty is not there. We're in a very old building that I don't dare to show even. This is the main campus of the University of Sydney. And many of my colleagues are also well-known researchers, and especially, for instance, my colleagues Professor Kerry Ballard and Professor Tricia McCabe do a lot of research in motor speech. So if you look at motor speech and treatment of speech problems, what every time comes up is yippee-yi-yo for the ex-UCIT students, principles of motor learning, neuroplasticity. Teach how to train the brain a new skill, how to teach a new skill to the brain, and use the ideas of neuroplasticity, or the principles of how we learn motor skills, principles of motor learning, how to reorganize the brain and retrain the brain. So if you want to learn a skill, you should exercise with large amounts. It should be random. There should be a random factor in it. It should be distributed. There should be external feedback, etc., etc. Now, this is how we learn a skill. And if you look at the summary of the principles of motor learning, it's high intensity, random stimuli, variation should be in there, and it should be complex. And there should be feedback. People should judge themselves, basically, if they're doing things correct or faulty. And this is how we retrain the cortex, and how we can train a young child to make the correct speech sounds. But that is not dysphagia. And what principles of motor learning has taught us, or neuroplasticity, is that you should train functional. If you train a sound or speech sounds, use those speech sounds, train those speech sounds. Do not do isolated exercises targeting and strengthening. If you have a patient with a dysarthria after stroke, don't do strengthening exercises for the tongue. Do really speech tasks and get the patient better. And this was what I was told when I came to Sydney, and I went like, yeah, but in dysphagia we do isolated exercises, and actually it works. And then my colleague said, yeah, but you know, ASHA has this review a couple of years ago, great review by Kathy Lazarus and Heather Clark and John Arvidson, which actually they did a systematic review on does oral sensory motor treatment actually work? So do isolated exercises work, yes or no? Well, the answer is we don't know. There is no evidence that it really works, but there's also no evidence that it doesn't work. But listening and looking at neuroplasticity principles, it makes sense that if you want to train a skill, you should train the skill itself and don't do any strengthening exercises. Because that counts for a lot of things in life. If you want to learn how to play golf, play a lot of golf. This is us many, many years ago when we were young, your first bike ride. Once, if you want to learn how to ride a bike, just try, fall off, try again and do it a lot. And at one point you master it. Speech sounds, tennis playing. If you want to be a very good tennis player, you have to learn the technique. And technique, the only thing that learns you a technique is doing it a lot. So tennis players spend a lot of time on a tennis court playing tennis. Is that correct? Well, not really, because if you look at golf players, which is a highly complex sport and uses a lot of technique, this is Tiger Woods, and he's a bit more bulky than I am, I think, if you look at his muscles, but off season, he spends a lot of time training his muscles. And if you look at Serena Williams, the ex-number 1 tennis player in the world in the female rankings, if you look at her, she's very, very muscle built. She looks very impressive. And those players spend a lot of time doing exercises aimed at muscle power and not only at skills. So it does make sense in complex things to have more endurance and have more power. You should not only do the technical training, but also resistance training and muscle training. And this makes me think, and going back to why I sometimes have a little bit of trouble with principles of motor learning and neuroplasticity in patients that have dysphagia. One of my most memorable patients was a patient that I once saw in Amsterdam many, many years ago. He was a 71-year-old guy with a brainstem stroke. So he could walk, he could talk. The only thing that he couldn't do was swallowing. He couldn't swallow, he couldn't even swallow his saliva, because he had a brainstem stroke and his brainstem was affected. And he had a very weak swallow, but cognitively there was nothing wrong with him. So if you look at his cortex, there is nothing to reorganize in his cortex about. So what we did with him was a lot of strengthening exercises, and actually he learned to swallow again, or in the end he swallowed properly again. One of the most utilized exercises in dysphagia therapy, I think, is the Shakir head tilt. And the Shakir head tilt, this is a slide I actually nicked of one of my students. If you look at the Shakir head tilt, it's an exercise you don't swallow, you just lie down and you raise your head. And the only thing is you strengthen the muscles over here by a concentric repetition, isometric and isokinetic exercise combination. You strengthen those muscles. And we know that in a geriatric population, this is a very effective exercise for pharyngeal dysphagia. And it's a great exercise to enhance laryngeal elevation. So This Shakir head tilt and the evidence we have around here actually defies the idea that everything we should do in dysphagia therapy should be principles of modal learning. So there is in dysphagia therapy definitely place for doing something which is called muscle exercise, muscle treatment, making muscle stronger. And that has probably to do with, oh, this is me being confused sometimes. Sometimes I am confused. And that has to do with the neural control of swallowing. Because if you look at a swallow, and that is where a swallow is different than motor speech, for instance, a swallow has a voluntary and an involuntary phase. And we know that in the oral phase, there's oral preparation, there is chewing, there is the collection of food on your tongue. You move your tongue from left to right. That is cortical controlled. That's voluntary. So if you have problems in that phase, it makes sense to train task specific. If somebody can't move his tongue to the left, make sure that there is a stimulus, a bit of yogurt on the left side of his mouth, and ask him to lick it off his lips on the left side, and he has to force his tongue to the left. That makes sense. That is functional training. This is where principles of modal learning come in. But if you look at the next stage, where we say it's a reflexive, which is not quite correct, because the swallowing reflex is not a real reflex, because a reflex is a neural arc that once initiated cannot stop. But a swallowing reflex is actually a cluster of patterned responses, which are motor activities which show some degree of subconscious programming, but can sometimes be overridden, because you can, if you need to swallow, you can stop swallowing sometimes. You can suppress a swallow if you really want. So swallowing involves some true reflexes and some patterned responses. And those responses patterned responses aren't stored, if you look at neuroanatomy, in the cortex, but more in the brainstem. And this is our cortex and our brainstem and our swallowing works. If the cortex, and when the cortex fires to the brainstem, in the brainstem there's a central pattern generator. Oh, sorry, you're over here. The cortex fires to the brainstem, the CPG, central pattern generator, located in the medulla, so in the brainstem. And once there is the signal you need to swallow, all the coordination for the pharyngeal swallow comes out of the brainstem. This also sort of shows and would explain why in patients, for instance, I worked in Germany with patients who were in a coma, that patients who are in a coma, they've got all sorts of oral phase problems, of course, because there is no cortical brain activity. But once you can trigger a pharyngeal stage swallow, actually most of those patients swallow isn't that bad, because the brainstem is still functioning, but not the cortex. And this is why my memorable patient of 71 years old with Wallenberg syndrome, who had a stroke here in the brainstem, has a beautiful cortex, no problems there at all. But if he wants to swallow, his brainstem just refuses, and everything after that doesn't do it. Now the question is, of course, can you reprogram a central pattern generator based on the principles of modal learning? Does neuroplasticity allow us to retrain CPG? Now that is a very interesting discussion to have with neurologists. And the answer is, so far we haven't seen very much research that you can actually do that. It works pretty autonomous at this point. So as long as this fires, so long as the cortex fires in CPG response, there will be a reflexive swallow. It might be very weak, but there will be something there. So can you then influence the swallow here by cortical reorganization? Or is the only component of the swallow that we can influence here, is that on a muscular level? And I think that in many cases, if you look at pharyngeal swallowing, it would be muscular level. And this would explain why a Shakir head tilt makes sense. Because a Shakir head tilt is aimed at suprahiatal muscles, which contract when the brainstem fires and make sure that your laryngeal, your larynx goes up and forward during a swallow. Why that would work? Because it's a strengthening exercise. And thus it will help you in curing a patient from pharyngeal dysphagia if the problem is laryngeal elevation. So this would allow me to think that dysphagia rehabilitation in many ways is pure muscle training when it comes to pharyngeal stage, and that's where I want to focus on. Now, this is a guy doing a side plank whatever. I won't it's Zoom, I'm not going to do this. I'm doing some exercise nowadays, but I get very tired when I look at this. But doing exercise myself in the last couple of years, I've learned that when I do exercise, I like to feel sweaty, I like to feel dirty. If you go to a gym, you want to feel exhausted afterwards, like, oh, I've been doing a workout, because that is muscle training. And maybe we aren't training our patients too hard, and maybe we should adapt a little bit more to the training exercises and the training regimes that, for instance, physiotherapists and exercise and sports science uses in how to train muscles properly, and maybe we can get better results out of that. If you look at another slide that I always love to show, is this Brody 1999, almost 21 years old. It's about the consequences of a swallowing disorder. Of course, we know that a patient with a swallowing disorder might have an aspiration pneumonia, and we have all sorts of other problems. And yes, if you have a swallowing problem, you might end up with decreased wound healing and pressure sores, etc., and all the medical problems you can have. But what I want to focus on in this slide is that if you have a swallowing disorder, you are very much prone, and we know that from our patients, to be in a malnutritioned and dehydrated state. Malnutrition and dysphagia go pretty much hand in hand. And by the time you start eating and drinking less, your muscles get weaker. And if your muscles get weaker, well, of course, your function decreases. So walking gets worse, but also your swallowing gets worse because those muscles will get weaker as well. And this is a nice catch-22 a patient can be in, because you eat and drink less due to dysphagia, your muscles decline, your swallowing gets worse. And if your swallowing gets worse, what you would do is probably eat and drink even less, because swallowing has become troublesome. And if you eat and drink less, you get weaker, so your swallowing gets worse. So this is a circle where we see our patients in. When I worked in the geriatric ward in Amsterdam, we saw sometimes patients coming in, very frail elderly, who were just very weak, and they had a swallowing disorder. And most of the men and women would have urine tract infections, which at that age is pretty normal, I think. And they were just weak. You can do a swallow assessment and you could do your swallowing therapy, but what I found so interesting is those patients would just get a nasogastric tube and the dietitian would just pump them up and boost the whole system, the patients would get stronger. And even without a lot of therapy, because they get stronger, their muscles get stronger, the swallowing gets stronger, and in a couple of days, the dysphagia just suddenly disappeared. So muscle strength and dysphagia go hand into hand. And again, we should maybe focus in our rehab more on treatment of the treatment of muscles alone. And if you look at treatment of muscles, you end up with things like treatment intensity and dosage. Now, this is very interesting because we all know, and some of us, especially now, COVID-19 is hopefully a little bit at a decline, and gyms are open again, so people are getting back to gyms again and trying to get rid of the COVID-19 kilos by sitting alone at home in isolation. We're doing a little bit more exercise nowadays. People do more strength training, and if you go to a gym and you do your exercises yourself, you know that if you want to change a muscle, you really need to overload the muscle. So if you can do a workout with a 10 kilo dumbbell, a week later you use a 12 kilo dumbbell or 12.5 kilo dumbbell to do your exercises, to push those muscles to a higher level, overloading. And if you do your exercises, you look at number of repetitions. So how many exercises do you do? How many sets do you do? Because you do a number of exercises, let's say 8 to 10 repetitions of an exercise. Then you wait 30 seconds or 2 minutes to let those muscles relax again and basically gain power again. And then you do another set of 8 repetitions and you have a rest and you do another set. This is how we train in gyms. This is how we train at a physiotherapist. And if you then look at how we train dysphagia and exercises, well, if you ask anybody how often would you prescribe an exercise to a patient, well, normally we would say, well, just ask the patient to do it 20 times per day or 3 times per day, 10 repetitions or something, or 20 repetitions, morning, evening, and in the afternoon. Well, a physiotherapist would say, or an exercise sports person would say, well, in the morning you do 3 sets of 8 repetitions with a minute rest in between. This is how we do our lunges and sit-ups and squats when we train at home. So maybe we should adapt to that. So it's about number of repetitions, it's about sets. And also if you look at what your training goal is, that's over here, the numbers of repetitions and sets that you do are correlated to your functional, the goal of the training. So if you want to have more power and strength, you have different repetitions or a different number of repetitions when you want to have endurance and speed. And this is something also relatively new, I think, to speech pathology and dysphagia therapy, because we just say to a patient, well, just do your Mendel zones. How often? Nobody knows. How many? How long? How hard? So we can learn a lot what exercise and sports tells us, and especially when it comes to loading. Exercises should be done either at 80 or at least 60% of 1 RM. And 1 RM means, for instance, if you can lift 10 kilos or 100, let's do 100 kilos. If you can lift 100 kilos, you should exercise with 80 kilo weights, because that's 80% of your maximum. And you do your exercises and you get stronger. And then suddenly you can lift, instead of 100 kilos, 120 kilos. And 80% of 120 kilos is 96 kilos. So instead of 80 kilos, you start training with 96 kilos. That will boost your muscles and create continuously overloading of your muscles. And that trains the muscles. And that's what you see when you go to a gym. You start off with small dumbbells, with very light dumbbells. And after 1 year, you go like, wow, instead of doing these exercises with 1 kilo, I can do it with 10 kilos now, because I trained my muscles. So that idea of overloading and increasing resistance and increasing load is something we can embrace in dysphagia therapy as well. Now, this is one, I'm very happy that one of my colleagues in our Faculty of Medicine and Health once gave me this slide. This is the American College of Sports Medicine. The American College of Sports Medicine is what it is. It's the College of Sports Medicine, and it's basically exercise and sports and physiotherapy. And it describes guidelines for exercise prescription. So if you want to do resistance exercise, which is really aimed at making a muscle stronger, you should work at 60 to 70% of 1 RM. I just explained what that is. And here is the number of power, the number of repetitions you do, and the pattern. So you would do 8 to 12 repetitions, and you do 2 to 4 sets. And that is if you go to a gym and you have a personal trainer, if they will say, well, you're going to do your crunches or your sit-ups or your lunges, do 8 of them, have a short break, 30 seconds, and we do another 8, and a short break, and do another 8, and this is how you get stronger. Now, this is how you would train a muscle. And again, in my research and in my idea, you can embrace that a little bit more. Also, if you look at muscle training, you need to know that there are different muscle fibers in our body. We've got slow twitch and we've got fast twitch muscles. And slow twitch are the ones that you use for low intensity activities and basically are aimed at endurance, like walking. And fast twitch are the ones that twitch fast contractions, but also get fatigued very fast. If you look at extreme athletes, you will see that a marathon runner would have a lot of slow twitch in his legs fibers, where a sprinter, 100-meter dash, those athletes will probably have more fast twitch or a lot of fast twitch because they can run 100 meters and then they're done, or 200 meters. That's typical sprinter. A sprinter doesn't run a marathon and the other way around. They can't do it. A marathon runner can't run fast 100 meters. It's all endurance that they're trained. And the other way around is the same thing. So a marathon runner won't do sprint training, and sprinter won't do marathon training. They've got specific exercises aimed at the specific muscle types. And this is from the website Bodybuilding. Great, I always love to. Bodybuilding.com, my favorite website. Training your muscles according to their fiber types makes sense. And how do you train to your fiber types? Well, you can do isotonic and isometric exercises, or a combination of both. And if you look at the muscles involved in swallowing, and I go back one slide, if you look at the laryngeal muscles, those muscles have a combination of slow twitch and fast twitch muscles. So basically, you should do exercise aimed at type 1 and type 2 muscles, fibers. So what type of exercises do we have? Well, we've got isotonic exercises, isometric exercises. And an isotonic exercise is a dumbbell curl or a squat, which you can see over here. You raise your arm and you have a contraction of the muscle, and you have a relaxation. You have a contraction and a relaxation. Isometric is like a plank. We all hate a plank or a wall sit. You go in a plank position and you stay there for 2 minutes and everything hurts in your body. All those muscles hurt, but it's a great workout and helps build those muscles. There's only one exercise that I know in dysphagia therapy that actually has an isotonic and an isometric component. And that's the Shakir head tilt, because you ask patients to lift their head for a minute and hold that in one position. So it's an isometric contraction of the muscle. Although if you do a Mendelssohn for a couple of seconds, that's also sort of an isometric contraction. Then we have concentric and eccentric. Concentric is a contraction, and eccentric is slowly relaxing again. And that's what you see if you, for instance, do a dumbbell curl. You would ask somebody, if you want to train your biceps, lift the dumbbell very fast, explosive, bang, lift it. And when you go back in extension, slowly release, because that slow release of the muscle and resisting that actually your arm drops down also trains the muscle. So it's not only the contraction, but also letting go gradually. If you do your lunges or your squats, if you do a squat, go down slowly, explosive up. Go down slow, up. Slow down and up again. This is how you train your leg muscles. Again, looking at swallowing, we don't really incorporate all these ideas. We just tell them, do a Masako maneuver, and that's it. Do a Mendelssohn, and that's it. Now, if you look at speech therapy in patients with head and neck cancer, for instance, and this is a systematic review we published a couple of years ago, we looked at in dysphagia, speech, voice, in patients with head and neck cancer, what does the literature describe about intervention and duration? And if you look at some of the quotes you see in speech pathology literature, there is a speech pathologist. And the patients were seen by a speech pathologist. What a speech pathologist here actually does, we don't know. Or even one paper, there was no speech therapy. Oh, that's very bad, that's very bad. But they don't describe what they're doing. So that's one group of patients, one group of papers. Now there's another group of papers that might say, well, there is a 6 to 10 exercise sessions were completed. But we still don't know what exactly happens in those exercise sessions. What kind of exercises? How many sets? How many repetitions? Because that all influences your outcome. In our systematic review, we saw that from the couple of hundred papers that we included, only 8 studies actually describe in detail that patients received speech therapy. 4 would describe that there were 4 didn't describe the number of exercises, nor did they describe what was done. There was just speechy hanging around doing something, and we don't know whether that was effective or not. And only 4 studies provide details on the intervention. If you can compare this to physiotherapy exercise papers, it's much more detailed, it's much more transparent what people do. Recently, this paper was published in Dysphagia, and it's called Dose Exercise-Based Dysphagia, a scoping review by Brittany Kreckler from Nadine Connor's lab, our president of Dysphagia Research Society. And again, they looked at everything that's published, and they recommend the inclusion of frequency, duration, repetition, and intensity components of exercise. And again, it shows that in speech pathology, in dysphagia rehab, we should have more focus on training and exercising and embrace basically a little bit more what our physiotherapists are doing. So looking at, well, this is a bad joke, refusing to the gym is not the same thing as resistance training, although this was me probably a couple of years ago before I started exercising. So are there any programs that look into treatment intensity and treatment outcome? So far I only know 2, and I know that some of you have already done the McNeill dysphagia therapy program. I must confess that I haven't done the program myself, although I know Giselle and Mike pretty well. The McNeill dysphagia therapy program is very intense, and what I know about it, it focuses on pushing the patient basically not to the limit, but it's really hard training and doing a lot of exercises and being intense. So that really embraces the idea of focusing on training and embracing those ideas of how rehabilitation should work. Another interesting concept is swallowing boot camp. This is MD Anderson in Houston, in the US. Boot camp, I love the term. Basically what this patient describes is how he with a chronic dysphagia went to the MD Anderson and had to check in every day at MD Anderson as an out-clinic patient and did 6 hours of exercise every day. He got a little bit of rest, but he did all the dysphagia exercises that they could find, basically. So they threw everything at him. And this is very high intensity. And in the end, he got better. While with other, let's say, low dosage dysphagia treatment, he didn't get his progression. So it shows that if there is limited literature out there, limited evidence, that's what I was looking for, limited evidence out there that actually high intensity exercises actually will get you to better outcomes. Are we doing things bad at the moment? No, absolutely not. I'm not telling you that speech pathologists are doing the wrong thing, because people sometimes say, Hans, you're telling that we're just doing a very bad thing. No, we're not. If you look at literature in general, and one of my current PhD students, Jacinda, is about to publish a systematic review on stroke rehabilitation in dysphagia. We looked in a meta-analysis how good we are, and if you look at standard therapy, whatever that may be, how that report is in literature, you see that we speech pathologists make patients better. We help. We are good. But if you embrace those ideas of muscle training a little bit more and work according to those lines, some of our chronic patients might benefit from that, and our patients that already are benefiting might be more efficient. We might get them faster from A, nasogastric tube, to B, full oral diet. Instead of 8 weeks, maybe we can do it in 4 weeks. So that is what our research currently is looking at. And this also a little bit would explain or looks at how novel interventions would work in dysphagia rehabilitation. Because if you look at dysphagia treatment, we've got these emerging modalities, as I call them, in dysphagia treatment. We've got VitalStim, started in around 2000. This is another, this is NROF with their electrical stimulation thing. We've got EMST, which is making a huge impact now, I think, in dysphagia world. We've got IOPI. Yeah, companies try to sell products. I'm not saying that the products don't work, but sometimes they work great for what they designed, and sometimes they also work a little bit for dysphagia patients. But are they really that good, is the question. Are they really efficient? So let's have a look at IOPI. I like IOPI, in all honesty. It's simple. You have a bulb on your, you have here, oh, sorry, we've got here your bulb. You have the bulb on your tongue, you press against your palate, and the patient can see how hard he presses. Simple biofeedback system, works fantastic to train tongue strength. I like it a lot. I've got a lot of IOPs in my office, and we do some research with it, and some patients get it. Take the machines home to do exercises with. Great, nothing wrong with IOP. It is reported that IOP also has beneficial effects on swallowing. Great, so if somebody trains that, his swallowing muscles get stronger. Great, we'll come back to that later. Same counts for expiratory muscle strengthening training. Also, again, an intervention that I really like because it's simple. Instruction is probably 2 minutes max for a patient. Blow hard through the tube. You can increase the resistance if needed, and you strengthen respiratory muscles. And if you cough stronger, if you aspirate, you cough stronger, you cough harder, you blow easier things out of your lungs, so you have less problems. You are less prone to have an aspiration pneumonia. Recent research, the last couple of years, also suggests that functional swallowing gets better. So pharyngeal stage swallowing improves when you use EMST. So you strengthen some of the muscles there, which would be great as a sort of bycatch, as a sort of side effect. But now again, you might ask yourself, is this all very effective and efficient? And this is one of the posters we presented on the Dysphagia Research Society last year, which is the research done by one of our ex-students, Debbie, who's probably online as well. So hi, Debbie, great to cite you. Thanks for all your great work. With my honors students, we looked in how effective, how efficient is IOPI for swallowing rehabilitation? And what we did is we looked with ultrasound, we looked at how muscles contract during the use of IOPI. And what we did is, and you can see here ultrasound, and we mainly looked at the muscles in the floor of the mouth, of course. So you could see how much they contract. And if a muscle contracts hard, the surface area gets larger because there's more contraction. Now the idea is, and that's the next slide, if you use IOPI, this is, you look at the cross-sectional area of the anterior belly of the digastric muscle, which is the main muscle that moves the hyoid bone forward during a swallow. And you can see that, I need to look at this one, that if you use IOPI, God, which one is that? If you use IOPI, there is an increase of the area, so those muscles contract nicely. But here you see IOPI, and here you see somebody swallowing hard. So actually, if somebody swallows, if you just ask a healthy volunteer, swallow, the muscle load is higher for your swallowing muscles than using IOPI. And this is also what you see in EMG. If you do surface EMG of the anterior belly of the digastric, this is during a swallow, and this is during IOPI. And you see that there is a lower muscle activity in those muscles during IOPI. So if you have a patient with tongue strength problems and you want to train tongue strength, IOPI is great. If the patient has tongue strength problems and pharyngeal dysphagia, and you might, as a sort of side effect, also have a positive effect on the pharyngeal stage dysphagia. But would you use IOPI as a primary exercise or as exercise only for dysphagia therapy? I wouldn't do it, because actually just saying to a patient, swallow hard, is more muscle load than using an IOPI for your pharyngeal muscles. And the same counts for EMST. And I know that the companies that make these products probably won't like this when you say that, because this is Christina's Petherick's study, and we look at the anterior belly of the digastric muscle. And if you look at EMST, so blowing and using your expiratory muscles, you see that actually the EMG signal here using EMST is lower than a swallow. And again, you see here a swallow, left, right, and EMST. So actually, you see that, again, it works great for expiratory muscles. If you use EMST, the cough gets stronger. I love EMST. Again, if I have a patient with a weak cough, EMST it is. Go for it. And yes, it has functional effects and it will train those muscles here a little bit. But if the patient really has problems in the pharyngeal stage, I would do a Mendelssohn. I would do also a Shakir head tilt, not only EMST. So are these products actually replacing what we are doing in exercise? No, it can help. It might be a little bit different, but if you look at efficiency, again, asking a patient to swallow hard 8 times as hard as you can, an effortful swallow. Swallow as hard as you can 8 times. Have 30 seconds rest. 8 times again. 30 seconds rest. 8 times again. 3 sets of 8 repetitions is probably more effective for the swallowing muscles than using EMST. If you ask a patient to do exercises only for swallowing, his coughing won't get stronger, so his expiratory muscles won't get stronger. If your target is that, use EMST. So it goes hand in hand. I'm not saying that you shouldn't use these products, but use them for which they were designed for, because there might be other ways that are more efficient. So the whole question is, can we make exercises also more efficient? And some of our exercises we can, because we started off with the Shakir head tilt. And I want to take you on sort of a journey where 2 years ago things started with one of our honor students, Sophia. I don't know whether she is online with us, or one of my ex-students now, Sophia Chen, who's now in Singapore, looked in the Shakir head tilt. We all know the Shakir head tilt. You raise your head, and this is me, by the way. This is my colleague Mark, and these are some. This is me, and this is Mark. And we looked at how much recruitment of muscles do you have during a head tilt, and I'll show you a little bit in the next slide. Here you can see that somebody is on a table and he's using his head and he's lifting, and this is Shakir head tilt, and hold it over there and slowly go back again, slowly going back. And what we actually did is what you wouldn't do with the patient. We asked the patient or the participants to lie on almost on the edge of a table, and we just let their head dangle all the way down, because we wanted to see if you would go full in extension, what that might do with those muscles as well. What you can see up here is the EMG activation of the suprahyoidal muscles. Those are the muscles that the Shakir head tilt is actually targeting. So those are the muscles that pull the hyoid bone forward and upward during a swallow. This is why they designed the Shakir. And this is the number of degrees. So this is in a supine position. So that would be lower your head, guy. Up. Yep. So if your head is like this, you would be at 0 degrees. And 60 degrees is really with your chin on your chin against your chest in the full upright position. And you can see that if you go up, let's go up. If you go up all the way, by the time your head is in a full flexed position, the activity in that muscle gets lower and lower and lower. And actually, if you have your head in this position, you are mainly using your sternocleidomastoid mastoid muscle, which is not a muscle that you use for swallowing. So what we designed, or what we are saying is, well, actually the most activity is between 0 and 20% incline. So instead of doing now patients doing a full Shakir head tilt, it's like doing sit-up and crunches. If you want your belly to be a little bit flatter, you don't do sit-ups, you do crunches. So ask a patient to lie down, lift his head just a little bit and back, a little bit and back, a little bit and back. You activate those muscles much more intense. And instead of the 60 seconds, hold your head against your chin, we just ask the patient, lift your head a tiny little bit so that your head doesn't touch the table or the bed you're lying on. So your head is suspended in air, but only to the point that you don't feel that your head is supported anymore, and hold it there for a minute. And then you are in this range. And this means that you are training those muscles much more intensively than with the 60-second chin to your chest. So instead of the Shakir head tilt, we would like to call it the Shakir crunch. We're trying to polish our data at the moment. And this might be a way of doing things more effective. Do I say that Shakir head tilt is ineffective? No, it's one of the most powerful training exercises we have. Can we make it more efficient? Yes, we can. So, where do EMG biofeedback and eStim fit in if you look at training of muscles? Well, if you talk about eStim, you talk about controversy. The thing you need to know is that eStim and biofeedback are no standalone therapies. It's not I'll slap electrodes to a patient, I'll switch on a machine and wonder, oh wonder, the patient doesn't have any dysphagia anymore. You have to do exercises that are aimed at strengthening, and an exercise aimed at strengthening with either EMG biofeedback or electrical stimulation is more likely to have a positive effect. But if you do an exercise that isn't effective at all, applying some electricity to it won't help a patient either. But we know from literature that if you use a targeted exercise in combination with EMG biofeedback or E-stim, you get to train your muscles more fast and more effective, and you will probably have thus a faster recovery of swallowing function. Now, if you look at your typical patient where you do SEMG biofeedback, you can see here on the left, this is a normal swallow and relax. So swallow, relax. You see a nice spike in the EMG signal. And if a patient does a Mendelssohn, you see that he holds it here for 10 seconds and then releases it. What you also can see is that the software will allow you, for instance here, or my software that I use, to have a sort of a threshold. You can ask the patient, stay above the line. Think back of American College of Sports Medicine. You have to train at a certain intensity. If you would say that this peak is 100% muscle contraction, you would, so 1 RM, you would be at 60, 70%. So I would draw the line here at 60, 70% high, that would be somewhere over here, and ask the patient, can you stay above the line and do your exercises? Now in 2 weeks time, if the patient does his Mendelssohns with EMG biofeedback and he gets stronger, his peak amplitude might go higher up. And if his peak amplitude goes up, my bar raises as well. I put that also a little bit higher up to make sure that those muscles keep on pushed for contracting harder and more intense. And this is really intensively training. And this is what we did with that memorable patient, one of the first patients I ever did EMG biofeedback with. Once I did a workshop with McNeill Huckabee in Germany, and I learned everything about EMG biofeedback there, and thought, well, let's try it in this patient. Very weak swallow. And what we saw is that this patient in his first session, if you would try to do a Mendelssohn, you could actually see he's trying to contract those muscles, but there is no stamina, there is no power in it, and actually he declines and declines and declines. Where after a couple of sessions, after a couple of weeks when we did this, he could do a Mendelssohn and prolong the signal. So those muscle is much stronger, he's got much more stamina, and his swallowing got stronger. And this patient hadn't been eating and drinking for 10 months after his brainstem stroke, and he had done speech therapy, dysphagia therapy in the hospital, in the nursing home, in a private practice, and nothing worked. So if nothing works, well, hey, I've learned something new in a workshop. Let's give it a go. So we got some EMG biofeedback stuff, equipment, and we tried. And actually, in 7 weeks' time, this patient got back to eating and drinking fully without aspiration. And I saw a lot of these patients during my PhD. And this is from my PhD. This is somewhere in the beautiful city of Leiden in the Netherlands, where I used to live before I moved to Sydney. The introduction of EMG biofeedback, we write in my thesis, not only might have given the patient more muscle control, but also allowed the patient to train his muscles at a more intensive level. Patients were really tired. They went like, "Ooh, I'm getting tired. I feel sweaty. I'm tired. I'm puffed." You go like, "Yeah, great. If I go to a gym after half an hour of exercises, I want to feel fatigued as well." And maybe these patients, we didn't do anything that extraordinary. We just upped the intensity, and we just asked the patient train harder and harder and harder, and we trained those muscles, and the muscles got stronger and his swallowing got better. And that's the same thing for neuromuscular electrical stimulation. I think E-stim is basically replacing the cortical input in a swallow, where normally the cortex would fire, and you can see here an axon, and this would be somewhere lower motor neuron. These are the end plates. So on this side over here you will have a muscle, and normally if you would swallow, your cortex would be involved, your brainstem would be involved, there would be an electrical pulse going through the axon, and here neurotransmitter will be released and the muscle will contract. What does E-stem do? By placing 2 electrodes on the skin, you create a force field, and actually within that force field, you make sure that there is artificially going to be some muscular, some electrical activity here in the axon, and neurotransmitter will be released and the muscle contracts. So actually you're replacing the brain, everything. In very short, if you have somebody who doesn't have any cortical functioning, and actually if you would take any live tissue, for instance, if you would take, let's say, if you would take a chicken that you just slaughtered and it's still sort of alive, the muscle, if you would apply electricity to it, it probably would still contract. So there's no cortical involvement, it's just pure muscle training, nothing else. But hey, it works. This is one of our first patients that we did with E-stem, a 64-year-old male, 4 years after stroke. Again, guy had a brainstem stroke, and he had several aspiration pneumonias, nil by mouth, expectoration of saliva, and here you see a fees. You can actually see that he is aspirating his saliva rather intensively. So what we chose to do is, let's try some E-stem on him, because I did a course on E-stem somewhere and thought, well, let's try, let's give it a try. What we did is, following rules for E-stem, we asked him to come 3 times per week. That's what physiotherapists would prescribe. We had 3 times per week, we had a session, and each session was twice 10 to 15 minutes of E-stem. And every 30 seconds, we asked the patient to swallow hard. If you would feel the current coming up, swallow hard. If you would feel that your muscles are stimulated, swallow hard. So the patient would relax, would feel, whoops, those muscles are doing something. I feel the electric current coming up. I need to swallow. Then you got a sort of voluntary contraction of the muscle combined with E-stem, and literature in physiotherapy will say that any exercise that you do where there is a contraction supported by E-stem, you will faster train muscle fibers and regain strength. So did this work in a patient? Yeah, it does. So after 4 weeks, you can see here again his larynx. This was prior to the therapy. So after 4 weeks, mind you, 4 years after his stroke, after 4 weeks of E-stem, he had a perfectly dry pharynx, no aspiration of pooling or saliva. There was minimal aspiration on 10 ml of thin liquids, no aspiration of thick liquids, and we started with an oral diet, and when everything went well, after 3 months we removed his PEG tube. So even in a patient 4 years after, we could regain his swallow and retrain his swallowing. What was the problem so far? Why would E-stem work in this patient? I don't know. I think so far what he's done is he has been under-training his muscles, and probably his intensity wasn't high enough to train. And with E-stem and the dosage that we used, that combination might have helped this patient. There's all sorts of people that find still E-stem very controversial, and it is controversial. And one of the things that you frequently hear is, we don't know what we're doing with E-stem, and that's somewhat correct, because if you look at research, you see that people use different stimulation parameters. For instance, this is a Marcy Fried and her colleagues started a commercial product which uses 80 Hertz and 300 microseconds and 1 hour of continuously stimulation. The question is, does that work or not? And there are people, hey, that's a very familiar name, who would say you use 30 hertz lower lower frequency and a lower pulse duration than the 300 microseconds, only 200 microseconds, and do it a couple of times per week, only 20 minutes. This is more, by the way, in alignment with guidelines for electrophysiotherapy. You might overstimulating muscles over here. But do we know what's happening in e-stim? Yes and no. We did a study that we're about to publish on displacement during e-stim, and we used all sorts of different parameters in healthy volunteers, and we looked if you would stimulate the floor of mouth muscles. e-stim would say, or the theory is, if you stimulate those muscles, the muscles will contract, and if those muscles in the floor of the mouth contract, your larynx goes up and forward. That's the aim of e-stim. By the way, we only use 2 electrodes, and they both are placed on the chin, between the hyoid bone and the front end of the mandibula. So you would expect that the larynx goes up. Well, actually, in many cases, you also see that the larynx goes down. Here you can see if you use an 80 hertz 300 microsecond, the larynx goes down. Actually, you pull the larynx down during a swallow. And that's also previously seen by research by Christy Ludlow, I think, a couple of years ago, who said, well, if you do video fluoroscopy on patients and you e-stim, then actually you draw the larynx downwards during a swallow. And only in a couple of patients, you see that the larynx goes up. Whereas if you use 30 hertz 200 microseconds, the majority of the participants, the larynx goes up. So there is a huge difference in what type of stimulation parameters you use, what you are doing. Is it a problem that you pull the larynx down? Might be. e-stim, the idea of e-stim is that you facilitate contraction and you facilitate a movement. Great. So if you would have this type of parameter, you probably are facilitating the best laryngeal movement, and that's what you want. So I would suggest that you use this time, almost these parameters. However, you can also say that if you actually pull the larynx down, it's harder for a patient to swallow. And hey, you've got a great resistance exercise, because the muscles that you use to lift your larynx upward and forward during a swallow have to work harder, because actually you're holding it down and you have to work harder. So in this case, it might be that e-stim is a great resistance exercise, and that's why it maybe helps. It's not in alignment with the ideas of functional electrical stimulation, but it works. So do we actually know what we are doing with e-stim? No, I don't think we are at the point that we can say we actually really know what this black box, how this unravels, and what's inside the black box called EMG. But if you see in the controversy that is surrounded by e-stim, and this is old PubMed, by the way, this is last year, if you would look at the evidence surrounding e-stim in swallowing rehab, this is a quick and dirty search. You get 700 papers about it. This is what a controversy does. Everybody jumps on the bandwagon and publish something. 700 papers on e-stim. How many papers do we have on the Shakir head tilt? 6, 5, 6, 7? How many papers do we have on the effects of thickened fluids? 2, 3? Masako maneuver, 2 papers maximum. 700 papers on e-stim. And if you look at a meta-analysis by Ding and colleagues in 2016, it shows that if you do a meta-analysis of all these papers on e-stim, the conclusion is that electrical stimulation as an adjunct therapy is more effective for the treatment of dysphagia secondary to neurological impairments than using the traditional therapy alone. So don't throw away the baby with the tub water, as we would say. Yes, there is still this part that we don't know, but in general, we know, there is a very clear trend that doing exercise with e-stim is more effective than doing exercise alone. And that's what I like sometimes about e-stim. Right, I'm coming to the end almost. And if you want to go down a very new path, there's also EMG-triggered e-stim. In EMG-triggered e-stim, and this is a slide that I nicked from one of my other students, ex-students who many years did a study on this. You ask the patient to do, for instance, a Mendelssohn maneuver. And this is a Mendelssohn maneuver with EMG biofeedback. You can program the machine as in a way that if you reach a certain threshold, so if there is an active component that the patient thinks, I need to swallow, I initiate a swallow and I'm going to swallow, that's very much behavioral intervention, neuroplasticity, cortical reorganization, looking at oral phase things, doing something with your tongue, etc. That's the behavioral, I need to swallow. And if you generate a certain force, the e-stim will kick in. So you will have, and the machine takes over. So instead of swallowing and having a very weak response of the swallow, you now have to swallow, think about swallowing, principles of motor learning, etc., neuroplasticity. But once those muscles start to work, they are supported by the e-stim. And we've done a very small pilot trial with a couple of patients, only with a very mixed group, but we got some nice effects in that. And I think if there is areas for exploring more research and making things very efficient, and you want to work with e-stim and want to work with EMG biofeedback, that as EMG triggered e-stim might be a very interesting way to look at in neurological patients. So I've been talking now for almost something over an hour. People who know me know that I love to talk, and I see that some questions are coming up. Great. How does this all end? Is there a conclusion? Well, the only conclusion that I have, and I'm almost celebrating the fact that I've been 25 years now a speech pathologist, and in those 25 years, I've learned that I still have a lot to learn. The more we know about exercise, the more we know about e-stim, the less we understand things. We need larger trials. We need to look more into what is it that we are exactly doing. Again, are we doing things wrong? No. We are effective. Are we doing a bad job as a speech pathologist? No. We calculated that our HSG, the effect size for standard treatment, that's Jacinda's research, is 0.7, which is a medium to large effect size, which is pretty good. So we're not doing things bad. Can we be more effective? Can we be more efficient? Can we get a patient instead of 6 weeks in 4 weeks away from the NG tube? Instead of 20 sessions, can we do it in 10 sessions? Maybe it's my personal psyche, the way I'm built, that I want things fast. Sometimes I'm a bit impatient in life. I just want to do things in 3 weeks and we're fine. Yeah. So can we up the stakes a little bit? Can we make our treatment more efficient so in less time get better results? That's also cost effective. That's how we show as a profession that we actually bring something else to allied health, that with a minimal capacity and a minimal effort, we have maximum results. So that is what we're looking. Is there one therapy or one exercise that will cure all patients? No. And if somebody tells you there is, don't believe it. There isn't, because dysphagia and swallowing problems are always a sequelae of an underlying other neurological or had a neck problem, there is something wrong. Dysphagia is not a disease in itself. Dysphagia is the clinical symptom of an underlying medical condition. So is there one thing that can cure it all? No. Does EMST work? Yes, great for your breathing muscles. Does it have an effect on swallowing muscles? Yes. Would I do a Shakir crunch instead of EMST to train those muscles? Yeah. If I'm purely looking at those muscles in the suprahyoidal muscles, I wouldn't do EMST if the patient has a very strong cough already, because it's an inefficient way to train. Same counts for IOPI, but if the patient is weak and has a very weak cough, I would love to do EMST, and I love to do IOPI. So really think what the underlying problem is in your patient and find the best working, the most efficient training parameter, the training exercise for your patient. Think what Jeri Logemann said. In dysphagia management, we should focus on rehab. But the problem in rehab, yes, is it takes a couple of weeks to get from A to B. You don't train a muscle in 2 days' time. In the meantime, the patient wants to eat and drink. So sometimes it works with a chin tuck, and sometimes it works great to thicken things up. Always target rehab. Rehab is the way to go, and make those physiological changes in a swallow, and make sure that the patient actually gets a better swallow. So to summarize a little bit about my sort of rant and my very weird mind and ideas that I might have about dysphagia therapy, of some of which you might think, wow, this is not how I would do it, but I'm always happy to discuss things, and this is very much also my personal ideas and my personal vision on dysphagia therapy. How would I use this all in therapy? If the patient has an oral phase problem, that means that there's voluntary control problem, I would definitely use principles of modal learnings and principles of neuroplasticity. Yes, I would do very task-specific training. That's where it works. And definitely there is no, I have no ground to think that it won't work. But if I look at the pharyngeal phase, which is more the patterned response and the reflexes, the only thing what I think is that you can work on is on a muscular level, because the brainstem takes over. This brainstem fires, yes or no, and if it fires, there is a muscular response, and the muscular response might be weak. This is where muscle strengthening comes in. This is where Shakir head tilt come in. This is where the American College of Sport Medicine's guidelines come in. Think in your therapy and think in your rehab patient that you see about dosage. Instead of asking the patient, oh, we're going to do a Mendelssohn now, say to the patient, we're going to do 8 Mendelssohns and we're going to do them hard. And after that, you can stop. We'll give you you have a breather, wait, and we do 8 again. And stop. And we do another 8 again. And that's enough for today. And we do another exercise. Yeah, so really look at muscle overloading if the patient is ready for it, because sometimes patients might be too weak. If patients are too weak, they can't do very intensive rehab. I know that. So that's why we have our thickened fluids and our compensation. But if the patient is ready to rehab, make them work, make them sweat. And I think we shouldn't be afraid that we are over-treating patients in speech pathology at the moment. I think in general we are under-training patients, and that is where we can make the next step in dysphagia rehab, getting the intensity a little bit up and getting more effect out of our exercises and getting a better outcome for our patients. And that is basically what I wanted to say. In the preparation for this little talk, I nicked some slides and some posters that I had and some presentations that I previously done with some wonderful colleagues. You can see the names here, Jenny and Clark, Mark Halaki, Fereshte, Pukazemi. Those are my colleagues within our faculty. And I also want to thank some of my ex-students. Some of them are here and listening, like Delal, Sophia, Jacinda, Debbie, Noor, Christina, and Jin, for their work and collaboration with me, because through work with students and working with students and their research as a supervisor, you also learn a lot. And being in Australia, you can't have a presentation without having a picture of the happiest animal in the world, the quokka, who is lovely, enjoying his green leaf and chewing it away and swallowing it without any problems. And that's it. And that is my presentation. So now let's see, what are we going to do? I need to open my, I'll stop sharing my screen. Okay, Nora, would you want to take over?
Yes, thank you, Doctor, for this amazing lecture. We had so much fun and we gained a lot of knowledge. There are some questions in the chat if you would like to read them. And anyone has questions, please do send them to the chat box. Thank you.
Yeah, I need to scroll a little bit through the chat box because I have been in private chats as well with some of my ex-students. May I record the lecture? I think it has been recorded. A copy of your PowerPoint slides and a list of references. Yes, I'll send that to the organizers and hopefully you can disperse that further. After the training, was the skill continue to be improved? This with regards to the eSTIM client. I followed up that patient for a couple of months, for 3 months. Normally, if a patient gets to the point where he can eat and drink and doesn't need his PEG tube anymore, we would normally keep the PEG tube in place for another 90 days to make sure that there isn't a relapse. It might be, of course, that, for instance, if the patient gets a flu or whatever or feels unwell, there is a relapse in his swallowing. And he might start aspirating again and he might need his tube. So in the hospital that I worked, we always said, well, if a patient is back to full oral feeding, we'll wait another 90 days. And if it's 90 days without any problems, then we'll pull the, we'll take the tube out. I think if a patient gets back to the point where he's eating and drinking 3 times per day and just has a brekkie, lunch and dinner, his swallowing is at that point so efficient that unless there is a progressive neurological condition like MS, MND, this is total something different than a stroke patient. But in a stroke patient, if you get them back to normal eating and drinking, I haven't seen many people relapse again and starting to aspirate again. So after the training, was the skill continue to be improved? Well, he swallowed fine and okay, and that's the last time we've seen him, and hopefully he is still alive. Is it helpful for esophageal dysphagia? No. Esophageal dysphagia, talking about eSTIM. Is eSTIM, could you use that on esophageal dysphagia? No. No, because esophageal dysphagia is the esophagus, we can't control it. It's different muscle types. If you look at applying electricity to those muscles, I wouldn't even know where you would place the muscle, the electrodes, because your esophagus is pretty deep down there. So I wouldn't use eSTIM for esophageal dysphagia. And I think esophageal dysphagia is something for our colleagues in gastroenterology and no longer for speech pathology. I wonder, do you also find improvement in voice? Well, actually, we did a trial with some patients with Parkinson's disease and IOPI. And one patient said that his voice had improved. Now, that might be very much placebo effect. I haven't looked at voice in all honesty. so improvement in the intrinsic laryngeal muscles. I stay away with e-stim from the larynx. I place the electrodes over here under the chin, and I stay away from this. I don't place electrodes over here, which vital stim will do, because for me it doesn't make sense which muscles you are hitting here. E-stim for me is trying to lift the larynx higher and making the laryngeal excursion, so the upward and forward moving of the larynx improve that. For that you use these muscles over here, and these are the muscles that I target. So if I do e-stim, I only use 2 electrodes and place them around here. By the way, it's also cheaper, which for a Dutch person is very important. We'll skip that one. Thank you. What is the best way to tell if your patient is weak? And what are your thoughts on the role of sensation, sensory impairments, and muscle weakness? Ooh, great. Great question, Emma. I think, and I hope, but I know that your PhD was focused on that, that one day we'll have good exercises and a good idea how we can train and improve laryngeal and pharyngeal sensation. Because if, in my idea, but I might be now cutting corners very short, many patients will aspirate, many patients will have trouble with residue here because they don't sense that it's there, they don't feel that it's there. So if we can train that sensation better and restore laryngeal sensation, so probably their cough reflex will be better. They'll note that there's something hanging there, so they swallow again, and they won't aspirate that stuff that's hanging around there. I would love to have good exercises to increase sensation, but so far, I don't think we have a lot. I have anecdotally seen patients that have had e-stim that would have silent aspiration, that after e-stimming the whole area here, that they would start coughing. That's anecdotally. I don't say that that is really a treatment effect. I've seen it, and I don't have a clue how that works and whether that is really structural side effect of e-stim. I don't know. I think we should do much more research in it. What's the best way to tell if your patient is weak? Yeah, if you do a video fluoroscopy, if you do fees, presence of residue suggests that muscles aren't working. You can see laryngeal displacement during a swallow. Based on that, you can say that a muscle is weak. But the question is, what is weak? That's also a very good question. Again, I think there is, down this track, more to explore, and we need to dig in deeper in what we are exactly doing. So hopefully in the next 25 years we've got enough work. Well, in 10 years I'm going to retire, so hopefully in the next 50 years we've got enough areas for research. But we might never ever get the full grasp, the full knowledge what we are doing or what we need to do. But I think slowly we're getting to the point where we do understand more and more about muscles, about laryngeal sensation. How do you guarantee lasting effects? Good question, Yuka. Lasting effects. Well, if a patient eats and drinks, like I said, normally I haven't seen any relapses unless there is a neurological condition that predicts a relapse. For instance, patients with MS. You know that we've been working in the Netherlands with a rehab center where they, our colleagues over there, regularly would do e-stim or biofeedback sessions on patients with MS to strengthen those muscles in order to prolong oral feeding in these patients. You can, with targeted exercises, if muscles get weaker due to a neuromuscular condition, you might keep those muscles more functional and maintain functionality of swallowing. The only thing you can't do is beat the underlying disease. So even in our clinical trial that we did here in Westmead Hospital in Sydney, where we did active exercises for laryngeal muscles and suprahyoidal muscles in patients with MND, ALS, where we saw some effects. In the end, the disease will catch the patients, unfortunately. But can you prolong oral feeding? Yes, you might. But again, we need more research in that. I see a good question about contraindications. Cardiac, hypertensive, surgical. Yeah, good question, Samira. Many years ago, there was a Dysphagia Research Society meeting where somehow a lot of presenters talked about cardiac problems, and we did measured hypertension in patients during exercise. Of course, if a patient has 6 coronary bypass grafts and has dysphagia and is in a cardiac on a cardiac ward, I'm not a speech pathologist who barges in and says, "Hi, we're going to do some exercises and going to work with you until you're going to sweat and you see black spots in front of your eyes." No, patients should be ready to do exercise. And I think you should be, in some conditions, you should be very concerned and always ask your medical officer and the medical doctor who is responsible for the patient whether you should do rigorous exercise or not. Even if you go to a gym nowadays and you have a personal trainer, sometimes they ask you to go to your GP and get you checked up before you do something. Go slow and always let common sense prevail what anybody else would say. So can you offer us treatment videos of swallowing problems with sessions in a direct way? Yes, but not now. Let's see. The lecture is discorded. How many swallowing exercises per session do you do? Depends on how many swallowing exercises do you maximum do, 2 or 3. Depends on what the problem in the patient is. In your assessment, you will find the underlying physiological problems that lead to a swallowing problem where a patient presents with. So you have to look with your FEES or your video fluoroscopy which part of the swallowing function is dysfunctional. Where do I see weaknesses? Where can training improve things? And if you know the underlying physiology, you can look on find exercises to train those aspects. So you might end up with 4 exercises, with 5 exercises. And based on that amount of exercises, I would go for your sets and your repetitions. So it depends really about the patient. It's individual. What I'm trying to say is there is no blanket solution to any patient. It's a framework. You have to think about what's the underlying problem, what is my toolbox with exercises that I have that might be or will be efficient for this patient, which exercise do I choose, and then think about treatment intensity and treatment dosage. All right, may I know your thoughts on exercises for individuals with cognitive deficits or issues with receptive language? Good questions. Yeah, Tanu, great question. Yeah, doing a Mendelssohn maneuver in a patient that has severe aphasia or a cognitive, an otherwise cognitive deficit is of course difficult. I don't do e-stim, by the way, in patients that have cognitive deficits, because e-stim, you might hurt a patient if you turn up the machine too high, and a patient should be able to indicate that something is painful and then you should stop. It's not torture. So that's why I don't like e-stim in very young children or people with a disability, a cognitive disability. Some exercises are just too complex, so you can't do it. But if you want to train these muscles over here and you want to strengthen those muscles, I said, well, it's not the most effective way to train, but for instance, if you would use EMST, which I still like, the side effect is you do something with those muscles, and doing something is always better than doing nothing. So, for instance, EMST is a very simple intervention that I would say, even with intellectual problems, people will still probably get that they need to blow through a tube, and that's it. Same counts for IOPI. We've done EMG biofeedback with patients with intellectual disabilities, and actually without explaining things and just graphically show what we want for sort of graph, they could pick it up. There are people who are developing software in that area. For instance, if you would swallow, that a monkey would jump, or an umbrella opens, or a plane will start flying. It's called serious gaming. We'll see that in the next, hopefully in the next years, more and more, that we have this type of software that actually makes training into a sort of a game, and makes it more like leisure, and makes it more fun as well. And that might be also something for that group of patients. And that's also very interesting to work in that area. I'll skip the one about Down syndrome, because I think I said something about intellectual disabilities as well. I wouldn't do things with eStim. Some things might just be too difficult. But again, if you look at our research so far, I think one of the best things for a swallow, and we are all clinicians here, we know that the best way to train a swallow is just swallow a lot. That's what I always used to say when I even worked in Amsterdam. If a patient can eat a bowl of yogurt without aspirating and safely, I'd rather have him eat 7 times per day a bowl of yogurt, or 3 times or 4 times per day, 20 spoons. That might be more effective than a speech pathologist coming in every 2 days for half an hour doing exercise. So maybe something like a boot camp, or saying swallow, swallow, swallow hard, swallow again. Maybe that helped. It might not be very creative therapy, but if it helps and it gets you from A to B, it might help you. All right. I wondered to the extent which reduced sensory input may cause reduced muscle contraction. Yeah, good question, Emma. Let's find that out once you're in Sydney. The connection between the two would be very interesting to see and to measure. And I think in that area, in the sensory input and sensory, like I said, there's so much we need to gain. All right. So what I understand, last question. So what I understand, that if you find 4 or 5 exercises that can help you, we'll do it all in the same sessions or separately. I would choose 3 exercises and do my sets and repetitions of that. In the next session, I'll do the other exercise. If I can see the patient every day, I would have a sort of a change in the program. Do this exercise, do that exercise. Make sure that they do all relatively the same thing. The same amount of repetitions. That makes it also a bit more fun for a patient, I think. A Shakir head tilt and a chin tuck against resistance is basically the same exercise, but for the patient it might feel a little bit different whether you sit with a pole like that or lie down and lift your head and do a crunch. You might do both. If I go to the gym, I do lunges, I do squats, and both are targeted at my limb muscles. And it's the same muscles we're targeting, but we do 2 different exercises, and that makes a little bit of variety in life. Makes it sometimes nice. Okay, final question. What are your thoughts on taking some of these therapy techniques forwards through telepractice? Yeah, good question. Unfortunately, now in COVID times, we have to do a lot of telepractice. Some of these exercises you can do. I think our Australian colleagues at the University of Queensland, Liz Ward, is the world expert in telepractice, in telehealth, whether she wants it or not, and dysphagia. there is no evidence that shows that dysphagia therapy via Zoom or via telehealth is less efficient than face-to-face. I think that actually COVID-19 has opened the door to doing more rehab via via telehealth. And actually, instead of a patient now coming to a hospital, or we are going to a patient and do a home visit, if the patient knows how to use Zoom, you'll save a lot of time on traveling, and that might be very efficient. So instead of having a patient coming in once a week, an hour, maybe it's more efficient to see a patient 3 times per week, 20 minutes via Zoom, and do the same exercises, and make sure, as a sort of your role as personal trainer, be there every now and then, 3 times per day for your patient in a very short burst. Do your exercises, motivate your patient. It might be even more effective. So that might be some of the silver linings of COVID-19. All right. Thank you very much for listening. I'm going to give the mic back to Nora. There are some other questions that I might email, or if you have other questions, always feel free to email me or direct messages through Twitter or Facebook or whatever social media platform. You know where to find me. Nora, thank you very much for having me, and it was a great pleasure and honor to share my thoughts and great questions as well.
Thank you so much, Doctor. It means a lot for us, and I hope you enjoyed it.
I enjoyed it very, very much, and I wish you a very everybody's safe future. For the Australians, enjoy your dinner in a moment, because it's 9 o'clock. To the Dutch people, I'll say, goeiedag, have a nice day. And to our friends in the Middle East, in Saudi Arabia and Kuwait, have a lovely, lovely, lovely Saturday and Sunday tomorrow. And hope to see you soon all again. Thank you very much.
Thank you.